Assalamu alaikum. Now we will talk about a common operation, which is cesarean section. Our objectives: you have to know the definition, timing for elective cesarean section, and its indications. It's good to know if you have the types of classification of the urgency. Also about the skin incisions. You have to know the types of uterine incision of cesarean section and the indications for a classical one. Also, you have to know what about information about the advantages and disadvantages of both types of cesarean section. The preoperative preparation and postoperative care is one of the mandatory points you have to concentrate about it because it's your part of duty. Also, complication is a very important point, and about episiotomy, its indications and types. Cesarean section is also known as C-section, or sometimes writing an abbreviation of CS. It is the use of urgency of surgery to deliver one or more of babies. The timing for elective cesarean section is about 38 to 39 weeks of gestation, and this is because we want to have good respiratory and lung maturity. The indications: we have two types of cesarean section, either planned, which is an elective, or unplanned, which is an emergency one. The elective cesarean section, for example, for multiple pregnancy, any multiple pregnancy with first twin is non-cephalic, it should be delivered by cesarean section. Breech presentation and transverse lie also should have cesarean section. Placenta previa and morbidly adherent placenta. The morbidly adherent placenta, we mean placenta accreta. All types of placenta accreta, once you diagnose it, you have to deliver by cesarean section. Mother to child transmission of maternal infection, for example, in cases of HIV or in cases of herpes simplex virus. Once the membrane is still intact and the woman has primary attack of herpes simplex virus, it's better to deliver her by cesarean section to decrease the transmission for the mother to the neonate risk of infection. Non-cephalopelvic disproportion, non-CPD, if the pelvis is inadequate, so it is better to deliver her by cesarean section. Fetal macrosomia, if you have large size fetus, estimated body weight more than 4.5 kg, you should deliver by cesarean section because we are afraid of failure to progress or shoulder dystocia. Vesicovaginal fistula repair, if the woman has a previous vesicovaginal fistula and an operation done for her, it's better to move for cesarean section delivery rather than vaginal delivery because in order to avoid the recurrence of such complication. More than 2 cesarean section, any woman presents with previous 2 cesarean section should have an elective dating for her next delivery. Unplanned, it means an emergency, and you all know many indications for an emergency cesarean section. The classification of the urgency: we have category 1, when there is immediate threat to life of the woman or fetus. Perform category 1 cesarean section within 30 minutes. For example, if you have severe abruptio placentae, severe shock, and you have to rapidly deliver the woman, resuscitate her rapidly and deliver her, you have to take an action within 30 minutes. Also, if you have cord prolapse, for example, which condition which impedes fetal life, so you have to deliver by cesarean section rapidly. You should not waste time in order to avoid the mortality or morbidity, severe morbidity. Category 2, when there is maternal or fetal compromise, which is not immediate life-threatening. It can be performed within 1.5 or 75 minutes. So, in cases, for example, you catch fetal distress, you can have time for putting the woman in lateral position, give oxygen, aspirate blood and prepare blood, and inform the theater for having an operation. You can have 1 hour for preparing the woman and delivering her. Category 3, there is no maternal or fetal compromise, but it needs early delivery. For example, if you assess your patient and you find that there is poor Doppler study and you decide to terminate her pregnancy, you have to take an action and deliver her, but it is not within hours. Category 4, it is the elective type of operation. Now we will move for the abdominal wall types of incisions. Skin incision, not uterine incisions. We have a commonest one is finished heel incision, and this is the finished heel incision. It is in the suprapubic area, and it has suprapubic area here, and it is smiling incision, and it is a commonest one. It has a benefit of having that this incision is within the creases of the abdomen, so cosmetically accepted, and it will heal rapidly without the risk of incisional hernia, lesser incidence of incisional hernia if you compare it with the midline incision, which is from the umbilicus downward longitudinally to the suprapubic area. This incision is called midline incision and it previously was done. And this incision in the skin, again in the skin, not in the uterus, this incision has poor healing, cosmetically is not accepted much, and with an increased risk of incisional hernia. But it has a benefit that this incision can be increased, for example, near the umbilicus and above it, to increase the surgical field, to expose the surgical field. Also, it has less amount of blood vessels and muscles because it is opened in the fibrous tissue between the rectus abdominis muscle to rectal abdominal muscle. While this incision, you cannot increase the size of it easily, and the accessibility of the operation sometimes is less with much blood vessels. But again, the benefits of finished heel incision is much higher than the longitudinal midline incision. Previously, there is a Joel Cohen incision, and this incision in the transverse, also in the lower uterine abdomen and the suprapubic area, but higher up, and it is straight transverse incision. Nowadays we are not use it. Sometimes Maryland, which is very less used, it is higher up, look like finished heel incision, but it is higher up and with much more bleeding. Uterine incisions, we have 2 types of uterine incision. That is the incision on the uterus. We have either lower segment cesarean section, we call it lower transverse, or lower midline cesarean section, and we have the classical cesarean section. The classical cesarean section is an incision, and this is the classical one, an incision longitudinal in the upper part of the uterus, and this is the lower segment cesarean section. And the lower segment cesarean section is more commonly used, while the classical or longitudinal or upper cesarean section has certain indications. If you have a transverse lie with spontaneous rupture of membrane, and the back is the presenting part, so you cannot deliver her vaginally by pulling the lower segment cesarean section and pulling the limbs, because the limbs will be hidden up. If you have structural abnormalities that makes lower segment cesarean section difficult, any abnormality in the uterus or in the field, surgical field, I cannot access the lower uterine segments, I will do longitudinal cesarean section. For example, the bladder is adherent, or I have bowel adherent to the lower segment, or difficulty in dissection, so I choose longitudinal cesarean section. Fetal abnormality, if you have conjoined twin or hydrocephalus, because this conjoined twin, it needs much space to be delivered. If you do the lower uterine segment cesarean section, which is the needed one and the commonest one with less complication, but it has a small accessibility. I cannot deliver large size baby, for example the conjoined or big hydrocephaly, from that incision, so I will choose that one which can be longitudinal and give good accessibility to the intrauterine components. If you have big fibroids in the lower uterine segment, I cannot do an incision in the lower uterine segment with this big fibroid because it will have bleeding and it will interfere with the surgical exposure of the field. If you have anterior placenta previa and big vascularity of the lower uterine segment, so if I open through the placenta, severe bleeding and intervention with the traction of the fetus and delivering will be difficult. Sorry. Mother is dead and rapid delivery is required. Sometimes if you have a medical disease or if there is an accident, RTA, and the woman is pregnant and was brought by the persons or the nursing staff and she is at once delivered, you have 5 minutes time to deliver the fetus and you can save his life. So you can do a longitudinal incision from the skin through the abdomen, through the uterus and deliver it because you need rapid delivery. Very preterm delivery, once there is lower uterine segment is not well formed and you do the cesarean section in the longitudinal type. So this picture shows to you the transverse incision. It is of lesser bleeding, easily healed and lesser risk of rupture, while longitudinal incision has more risk of bleeding, more risk of rupture in the second or successive pregnancy, and it is difficult to heal. Sometimes if I do transverse lower segment cesarean section and it is difficult to manipulate or deliver the fetus, I can extend the uterus by like this incision. We call it inverted T incision. This picture also in A is the lower segment cesarean section, and this type also lower segment but the longitudinal. It is also have lesser bleeding and easily to heal. But this is the classical one, which is much bleeding with difficult to heal and risk of uterine rupture. Sometimes if you need to increase the size of lower segment cesarean section due to difficulty manipulation and delivering the fetus, I can either extend it laterally up or in the midline as inverted incision. Why I cannot do a transverse extension more? Because the ureter is here on the side of the uterus with the uterine artery. So once tear occurs transversely more, it will injure adjacent vital organs. The advantages of lower uterine segment cesarean section, as I mentioned, it's less risk of infection, healing is better, risk of rupture of the scar in the successive pregnancy is less, hemorrhage is less. The disadvantage of the lower segment, the operation requires skilled person because I should dissect the lower segment from the adherent bladder to it, and the incision may extend down to the bladder. Sometimes if you don't extend it by yourself, by manipulating, as we mentioned, inverted T or the lateral edges, it may extend to the bladder and cause injury to the bladder. The classical operation, it has more risk and more liable to have intestinal distension and peritonitis, and the scar is easily ruptured in successive pregnancy.